Okay, Tracy.
Good morning, everyone. Thank you for joining us. This is Tracy Morton at the National Rural Health Resource Center, and I'm joined in the office today with Margot Kalsa, Cami Norland, Corey Bjerk, and Nicole Clements. And we welcome you to our second webinar regarding HCAHPS, entitled Moving HCAHPS into Practice in Critical Access Hospitals. Thank you so much for readjusting your schedules to be able to join us here today. We apologize for having to reschedule the webinar from yesterday to today. We had some emergency flash floods here in Duluth yesterday. Pretty devastating conditions out there. Luckily, most of our staff are just fine, so we're very grateful for that. We're just thankful to be here and be able to share this information for you that we've been working on over here at TASC. At the Technical Assistance and Services Center, we were awarded a supplemental fund from the Office of Rural Health Policy to develop some resources and increase education and awareness about HCAHPS in alignment with the Medicare Beneficiary Quality Improvement Project, especially Phase 2, which addresses incorporating HCAHPS and measurements into critical access hospitals. So as part of the work plan for that, we developed a directory about HCAHPS vendors, which we'll be sharing with you today, and just have some additional information and education to share about how critical access hospitals are using HCAHPS and some of the benefits and barriers to using HCAHPS in those facilities. So with that, I'm going to turn the call over to Cami Norland, who's going to lead the discussion today.
Yes, thank you, Tracy. Hello, everybody. My name is Cami Norland, and I'm the Community Specialist here at the National Rural Health Resource Center. And I have created a presentation for you on moving HCAHPS into practice in critical access hospitals. So at the office here, I'm always asking or searching for the why in the tasks I'm charged with. Which is one reason why algebra was one of my weakest subjects in school, because I just couldn't figure out why it was important to figure out X, for instance. I just didn't see the value in that. So in keeping with that same spirit of always searching for the why, that bigger picture, I also sought the why for HCAHPS. And one of those whys is that I discovered an astounding fact by the Commonwealth Fund that said 1 in 5 Americans, that's 22%, report that they or a family member have experienced a medical error of some kind. Now, nationally, that translates into an estimated 22.8 million people with at least one family member who experienced a mistake in a doctor's office or hospital. And according to the CDC, there are an estimated 1.7 million hospital-acquired infections each year, which results in approximately 90,000 deaths. A recent study in emerging infectious diseases found that hospital-acquired infections are the 6th leading cause of death nationally, costing the healthcare industry $6 billion annually. And at least 44,000 people, and perhaps as many as 98,000 people die. And these are those that are reported in hospitals each year as a result of medical errors that could have been prevented. And those statistics are according to the Institute of Medicine. And these figures are so astounding that 1 in 5, I took a look around the office here, and I've got 5 pictures of TASC staff held up. And take a look around the room where you're at, or think about your family members, and note how 1 in 5 will report experiencing a medical error. I think that is completely unacceptable, and it needs to be changed. We need a process to correct these statistics, and I think HCAHPS attempts to do that because they help identify those faulty processes if those HCAHPS patient satisfaction scores are linked to clinical and quality outcomes. I'm having some difficulties changing the slide. Thank you. So what are HCAHPS? HCAHPS is Hospital Consumer Assessment of Health Providers and Systems. It was developed by CMS, the Centers for Medicaid and Medicare Services, in partnership with the Agency for Healthcare Research and Quality in 2002. It includes a standardized 27-question patient satisfaction survey tool and also the standardized data collection method as well. Prospective payment system hospitals are required to complete and administer HCAHPS, although critical access hospitals are strongly encouraged to administer and report on HCAHPS. Participation at this point is voluntary. Pediatric, psychiatric, and specialty hospitals are excluded from participating in the HCAHPS process at this time. So the standardized survey tool must be facilitated by a certified vendor or self-certified vendor if strict criteria is met. So that means that in order to become certified, these vendors needed to undertake a training that was held by CMS, and they need to stay consistent with those certification processes and be compliant in each of the method of which they administer the surveys, collect the data, and then report the data back to CMS. So the surveys are administered to a random sample of adults 18 years of age or older to discharged inpatients. The surveys need to be sent out within 48 hours to 42 days of discharge. These inpatients need to have received medical, surgical, or maternity care. And then that survey needs to be distributed in one of four methods, either via a mailed survey, a phone survey talking with an individual person, a live person, the interactive voice recognition system, which is the computerized phone telemarketers that we've had, or mixed combination of both mail and phone. So the questions that are asked on the survey tool really reflect that patient perspective, and they look at pain management, medication instructions. They're trying to find out the cleanliness of the hospital environment, the quietness of the hospital environment. They also look at the effectiveness of communication with the nurses, with the doctors, the responsiveness of hospital staff, communication about medications. When you were in the hospital, were you informed about what the medication did, the purpose of the medication, what the dose was, the frequency of taking that medication? Were you given instructions upon discharge about the medications that you'll be leaving with, or any coping skills that you'll need to address to accommodate your recent surgery or hospitalization stay? And then patients are also asked about their overall satisfaction and whether they would recommend the hospital to others. The standardized survey collection process was designed to assist in enabling meaningful comparisons across hospitals for public reporting, increasing hospital accountability. So if the hospital is receiving low patient scores, are they following through on that? Are they trying to identify opportunities for improving that performance? Are they creating incentives within their staff and healthcare providers for creating activities of quality improvement? The standardized survey collection process also enhances public accountability. The public is learning about Hospital Compare because the data that is collected from the survey mode, the mailed surveys, the phone surveys, that data is sent to CMS quarterly. And only the positive or top, what they're calling top box scores are reported. So that means individuals that respond to the survey as always. They always received communication regarding medications. They always received a quiet environment, those types of things. Only those top scores are reported to CMS. And then those percentages are reported at hospitalcompare.hhs.gov. And the public is starting to learn about these scores, and they're making their healthcare decisions based on Hospital Compare. For instance, I was conducting a focus group in Indiana, and I was speaking with one of the Amish there, and he was informing me about how the processes that they make in their decision-making processes for selecting a hospital, because they have a lot of births, and so they have 8 children, so they're always in the hospital. And so they want to make sure that they are receiving high-quality care and that the care is going to be cost-effective. And so this gentleman reported that his church network will go through and they will find out the price of services available in the region for say, a delivery. They'll also look at Hospital Compare and see which hospital has the greatest satisfaction. And this is happening in the Amish community. So if the Amish community is being this advanced and progressive in their healthcare decision making, think about what the rest of the population is doing, since the Amish is historically preserved in the 1800s. So just some thoughts for you to think about as the public accountability is really enhancing here. The standardized survey collection process also prepares hospitals to link reimbursement to quality and performance. And when you tie those survey results to clinical outcomes, you're going to see that a reduction in hospital readmissions. You're going to see a reduction in hospital-acquired infections. If you're looking at some of those processes of, even simple processes of our nurses and providers washing their hands upon entering, did the patients see that the nurses are sanitizing their hands before they enter and as they exit your room? These are some of the processes that can assist in creating those survey results linked to clinical outcomes. And I have a little cartoon here. It's hard to read the text, but it says, "It's all right for you. You're going home today," as the one who is going out has a nice smiley face, and the one staying in the hospital is kind of grumpy, perhaps due to her readmission or her hospital-acquired infection. So the point that I'm trying to make here is if we link patient satisfaction to hospital operations, what we're going to see on the left-hand side is we're going to see an increase in patient satisfaction. You're going to see the A-OK sign there from the patient who is receiving care. In turn, the hospital's reputation is going to increase. And on that balloon there, it says a reputation that took decades to build can be threatened by a single event. Now, this is so true because people out in the rural communities, they're talking, and word of mouth travels so fast. We know that people at the local diner and the barbershop are sharing their stories about their recent healthcare crisis that they had. In fact, Terry was in the office the other day and was explaining how he was in the emergency room at a hospital locally and experienced a very negative time there. The staff were grumpy. He waited in the ER for a really long time. The processes were very inefficient. Now, the fact that all of us here in the office heard about that just reinforces that people are talking out there. And he had also indicated that he's never going to go to that facility again because of the poor experience that he had in the emergency room. And that emergency room is the entry point to the hospital services. And that word was shared here, and then everybody else chimed up saying, "Oh, you know what? I've had a bad experience there too," and that reputation is spread negatively. But turn that around, and what if he had a very positive experience? he would also be sharing that information with us. He would be telling us that the staff there were so friendly. They really responded to the needs of his family member. They took good care of him. They explained the medications and the procedures very thoroughly, and he'll be back. And so what that does for the hospital's reputation is that positive word is going to spread. And when that positive word spreads, you're going to increase the volume of your market share. And one of the goals, or the keys to financial success of a critical access hospital is capturing that full market share within your service area. So everybody that was in your service area is coming to the hospital, the local hospital, for your services. And I think this slide really demonstrates the power of a standardized patient satisfaction tool and standardized collection methodology. If you can link that satisfaction to hospital operations, this is going to affect the hospital's bottom line. So as Tracy had mentioned at the start of this call, HRSA's Office of Rural Health Policy has charged the National Rural Health Resource Center's Technical Assistance and Services Center, TASC, with capturing a body of knowledge regarding the benefits and challenges of implementing HCAHPS in small rural hospitals, particularly critical access hospital settings. So we convened a small group meeting in April of 2012 in Denver, Colorado. We tagged it on to the National Rural Health Association annual conference. And attendees included flex coordinators, Office of Rural Health Policy staff. We had a few vendors present. We had some critical access hospital CEOs. We had some rural health networks, some state hospital associations present. And we had a really inspiring conversation identifying those challenges and benefits for implementing HCAHPS in a critical access hospital setting. Some of those benefits that were identified by your peers here was the ability to benchmark performance and quality measures. It was an opportunity to showcase high HCAHPS results. If you were present on the Task 90 call last week, Michelle Casey with the Flex Monitoring Team indicated that critical access hospitals have an average of 5 to 10% better patient perception scores compared to urban facilities. Now, this information just justifies the value of rural hospitals being in the rural communities. And if you have not checked out that report, I strongly encourage you to go to the Flex Monitoring Team website. And that link is included in the directory that was sent to you earlier this morning. They also identified that public reporting encourages a process of improving care and performance linked back to hospital strategy. That whole concept that I was just talking about a couple of slides before. Individuals had also noted that if these scores are added to the balanced scorecard or Studer pillars or any sort of performance management framework that you're utilizing, it can really elevate those scores and help translate the HCAHPS data into operational practice. Some of the challenges that was identified in this group was cost. Critical access hospitals are concerned about the amount of money that they need to invest in this process of both surveying and then developing quality improvement activities. They were also concerned about obtaining a meaningful response because patient perspective or PBS hospitals are required to submit approximately 300 surveys, and that is not feasible in all rural communities when perhaps you have one or two or you have a very low volume of responses. There was also some concern that the public perception of these low volumes could be perceived as a negative trait for a care provider. For instance, if you see that only one or two people received that surgical procedure, maybe you're less likely to go to the local hospital to receive that procedure, and you'd be traveling to the urban facility. But that may be just due to the low reporting. There was also the opportunity of, or the missed opportunity rather, of service recovery. And what I mean by this is there was the perception that if the hospital did something wrong, had an error in the patient's perception, they didn't find out about it until, maybe a quarter later. And so that was a missed opportunity for them to try and recover that service with the patient, try and make amends and correct that behavior. It was so past the fact. So those are some of the challenges that were identified from this group. Another area that the task was assigned with was identifying a vendor-director methodology. And one of our new staff members here, Corey Bursick, was available to assist us in this process. Corey, could you outline the methodology for this vendor directory?
Yeah, definitely. So we started out by kind of compiling a list of basic information for all of the vendors, and there were almost 40 vendors total, and these were all trained and certified by CMS to administer the HCAHPS survey. So once we had that kind of basic list developed, we were able to develop some questions to go through with each vendor, and you'll see these in the directory. It ended up being an outline of these questions, and those included inquiries into the contact information, obviously, for the vendors, where they offer their services, their experience with the smaller rural hospitals, which survey modes they used, and then a checklist of their services, an outline of their cost structure and price. And then we also looked into the frequency of reporting back to CMS and the frequency of reporting data back to the clients, which would be the hospitals using the vendors. And then, of course, we took note of any additional information provided by the vendors, and that's just kind of tacked on in the directory there. So once those questions were developed, we were able to contact each vendor directly, and all of the vendors in the kind of database we chatted with over the phone. So some of them gave us information via email as well. So we gathered the information that I just mentioned, and 26 vendors agreed just right away to provide the information, and then there were a number of vendors who opted out because they don't really offer services specialized to the rural, smaller hospitals and communities. So 5 vendors opted out, and then there were a couple vendors that no longer provided HCAHPS services, and then there were also a couple vendors who were unable to return our inquiries, our calls, and emails for whatever reason. So they weren't included in the directory. And once we kind of got in contact with all of these vendors and chatted with them or emailed them, we were able to kind of outline the information they provided and then we sent it back to them for their review. And then once we received it, we took their kind of edits and recompiled everything. And of course, we've made effort to make the directory as neutral and unbiased as possible. And so I made most of the calls myself, so I still have my notes, so if anyone has any questions, I'm available, and I'm sure the rest of the task staff is as well.
Great. Thank you, Corey. It was very helpful to have you make those calls. I know it was often laborious to be trying to stay in touch with them. So as Corey had mentioned, 21 of those HCAHPS vendors report some experience working with small rural hospitals, and 16 report specializing in rural. And we verified those that reported, quote, specializing in rural by requesting them to identify some of those unique features of working in a critical access hospital, such as workforce shortages, HIT implementation. Also, if they could identify that It is very common that many staff wear multiple hats and that sort of thing. And so we had some good conversations with a lot of these vendors. We did an assessment of the modes of administering HCAHPS surveys. 17 of the 26 offered mailed surveys, 15 phone surveys, 3 offer the interactive voice recognition, that's the computerized voice, and 7 offer a mix of mail and phone. Now some of these also offer both mail and phone, but not the interactive. Each vendor seemed to have their own preference for which mode returned the greatest response rate, but we found no conclusive evidence indicating preference from one over the other. Although we do note that phone surveys enabled a quicker turnaround of data back to the hospital compared to mail. We also referenced the third quarter of 2011 data from CMS reports, and they indicate that 62%, that's 2,470 hospitals, used mail surveys, so that's the primary mode of administering HCAHPS. 37%, or 1,468 hospitals, used phone surveys. 0.4, or 16 hospitals, used the interactive voice recognition, and a mere 5 hospitals used a combination of both mailed and phone surveys. We also requested that the vendors identify any of these following services, and we asked them to identify if these services were available at an additional charge or if this was included in their basic HCAHPS package. And there's a great variety. I encourage you, a great variety of responses, so I encourage you to take a look at the vendor directory and review which of those service offerings meets your needs best. For instance, multilingual survey options was standard for some facilities, some vendors, and others charged additional for that option. We took a look at the cost for HCAHPS, and there was also a great discrepancy in the way that individual vendors charged for their HCAHPS services. The range was between $1,461 and $6,260, with the average cost of about $3,500 annually. Now, some of those differences between costs, some provided or would charge an annual fee, and then they would charge a fee for each survey that was sent out. For instance, if it was a mailed survey, some would charge per response rate, and then you would only pay if you had, say, 200 responses. Others charged for each mailing, each attempt that they made to try and get a response rate, and you paid regardless. And that difference is indicated in the vendor directory as well. So taking a look at how Flex coordinators can use the HCAHPS vendor directory, I encourage you to review it and select the vendors for hospitals to receive maybe perhaps a group network pricing. You could also forward the directory onto your hospitals to have them review it. You could monitor their HCAHPS participation. You could provide some technical assistance and education for quality improvement. You could provide them with additional tools and resources on some of those techniques, like the management frameworks of a balanced scorecard or the Studer principles, Studer pillars. Lean technology is, or the Six Sigma is also a popular method for increasing the quality improvement. Nicole, could you please post up the PDF that we have of the vendor directory? And if you could just scroll down to a page that indicates the vendor directory for me, please. I would just like to walk through what the vendor directory looks like. So you can see on the the top here that we have the name and the contact information, and Corey has verified that Patrick Sells is indeed the contact for Alexandria Marketing Research Group Incorporated and where they're located. We indicate their location of services offered, their level of experience. We see that this facility enjoys working with small rural hospitals. They provide the mail survey mode, benchmarking data, multilingual survey options are included in their basic HCAHPS service. And if you scroll down to the next page, you'll see that their cost structure and price, how that is outlined, and some indicated that they would like individuals to contact them personally for a quote, which is just fine. We see their frequency of reporting to CMS and also back to the hospital, as well as some additional information that they have provided. And when you take a look at this information through each of the 26 vendors, you can really get a sense of where they compare and contrast. At this time, I'd like to open up the lines to see if people have any questions regarding the vendor directory, regarding HCAHPS. And then after that, I'd like to have a conversation with you folks regarding what you're seeing in your states, what are the perspectives of HCAHPS in the critical access hospitals in your state, what are you experiencing, what are those challenges, and also identify some of those resources and tools or consultants that specializes in translating some of that HCAHPS data into quality improvement initiatives. TASC is always in the process of maintaining a list of resources, and we have some of these tools and consultants available that we could forward on to you if you're interested. And if you know of folks as well, or if you know of really stellar processes, we would love to hear that information and share that with others. So at this time, I'd like to open up the floor to questions regarding the vendor directory or HCAHPS in general.
Just a reminder, the phone lines are muted, so if you would like to add to this conversation, please press *# to unmute your line.
Tammy?
Yes.
This is Kevin Dreesen, and I want to congratulate you. I think the vendor directory is going to be very useful. Several of our hospitals here in Arizona have recently either identified or begun looking for vendors, and so we will distribute this, and I appreciate your work. It seems to me in one of our visits a couple months back to a hospital down in Cochise County that they were able, through their vendor, to identify unit-specific information on satisfaction. And I'm wondering, in your presentation, did you cover their abilities to, look at certain units, specific units within the hospital?
We did not. We focused purely on just the hospital, just the HCAHPS survey. We didn't look into any of the departments.
Well, for example, like the emergency department or for laboratory services, are there, in terms of your questions of your, when you interviewed the vendors, that wasn't one of your questions of whether they're able to separate out or add a data field that would separate out their findings for the different departments?
It was not, however, in the additional information section of the vendors. A lot of them do specify that they have that capacity to do it. And those that, and I guess I'm only making the assumption that those that indicated that in their additional information are those that provided it, and those that did not indicate it are not providing that type of service.
Yeah, that was part of the difficulty in creating this directory is there's so many additional services offered, and it was hard to keep track and compare apples to apples between the vendors. But that's definitely noted in the additional information section for each vendor. And a lot of them do offer that departmental specific details. and surveying.
This is Patrick Lipford with a question.
Sure, go ahead.
Okay, I didn't know if my microphone was on or not.
Yep, we
Thank
hear
you.
Mm-hmm.
Is the vendor list a list of authorized vendors by the Federal Office of Rural Health Policy and the Rural Health Resource Center that have been vetted, or is this just merely a list of names and addresses of consultants that do this work?
Excellent question. These are those that have received CMS certification to administer HCAHPS. And so ORHP and the Rural Health Resource Center did not endorse any specific vendor out there. These are those that just are certified, and they are identified on the CMS Hospital Compare HCAHPS vendor list. And so we just took that list and we contacted all of those vendors, and these are the ones that responded to us.
All right. Thanks for the clarification.
Yes, you're welcome. Carol Bischoff, are you on the line?
Yes, can you hear me?
Yes, thank you.
I'm here.
You're doing some interesting things in Montana regarding HCAHPS. Could you share a little bit about what is happening in your state?
Certainly. So we've got like 3 main areas that we've been working on in regards to HCAHPS. The first one is really just kind of what you did today as far as creating an awareness of what HCAHPS is, what it's all about. We actually started that last fall with we do a series of meetings with the critical access hospital administrators, and then another set of meetings with quality coordinators and nursing directors. So we focused on providing some education about HCAHPS, its part in MBQIP, et cetera. And then actually we hit that same topic again in spring meetings with each of those same disciplines. In between there were a lot of questions, which we tried to, deal with one-on-one. So really that was one arm. I think there were just a lot of questions on the part of the hospitals as far as what's involved, what do we have to do, what's a certified vendor, all those kinds of questions. So part 1 then was just raising awareness and providing education. Part 2 of what we are doing here in Montana is we have a clinical benchmarking project that includes a variety of clinical measures that the hospitals can report on, as many as they want or as few. We just ask that once they pick a subject area that they report on the measures of all those within that subject area. So for example, we have measures on falls, and they're usually related to studies that we've done, or pressure ulcers. And so based on feedback from mainly the quality coordinators and the nursing directors, we actually added the HCAHPS measures. It turned out to be a separate benchmarking project, but again it was in an attempt to educate the staff at the hospitals as far as what data they would need to start collecting, and just give them a venue to report. And then I think you mentioned something about benchmarking, and so that was a way for us to at least provide some benchmarking within the state of Montana. So that started, the facilities were able to start reporting that data to that project the 3rd quarter of 2011. And we've done it now for 2 quarters. We've got 9 hospitals that are utilizing that service. And in addition, underlined both of these projects, we've worked very, very, very closely with our quality improvement organization, and so they've been helping us a lot. We track with them who's reporting, and I think right now we've got 13 hospitals that are reporting. They've got some vendors, they've established a vendor relationship But that number is old. I'm sorry I don't have new data to report, more current data. But probably the biggest thing we've done is we had one of our critical access hospitals in Big Timber, Montana that employed the services of a company called Custom Survey Solutions, which is housed in Big Timber. And they are a certified CMS HCAHPS vendor. And so since the Montana Flex program is housed within the Montana Hospital Association, we were able to buddy up with the group purchasing arm of the association, and the director of that group purchasing services was able to create a pretty sweet group purchasing option for the critical access hospitals with this Montana-based company, which is a very key selling point for Montana residents. If we can keep our business in state, we like to do that. So that was a huge boon. This was an all-inclusive cost of $3,200 a year, and they've got a good track record. They enlisted a couple hospitals early on, and the word of mouth advertising was very good. So I think, and this program was made available earlier this year, and and I apologize, I didn't come prepared to tell you how many hospitals are actually taking advantage of it, but I know that they were real happy to hear this news. So those are basically our three activities, along with the collaboration with the QIO.
Yeah, thank you, Carol. And Nicole, I think we have their vendor profile included in the directory. If you could scroll down to that, I saw that you could feature that.
What was it?
It's called Custom Survey Solutions in Big Timber, Montana. And if you don't, I'll be happy to share their. And again, remember, this was a group purchasing price that I listed, not their standalone price.
Sure. Thank you,
but
Carol.
I'll be happy to.
Thank you, Carol. That would be great. Thank you.
You're welcome.
It sounds like you're doing some great work there. And what I is the partnership with the QIOs there. I think that they can really be beneficial if you partner with the QIOs and that follow-up piece of process improvement.
Yeah, we've been inseparable partners for a lot of years, so this was just an extension of our relationship.
Excellent. That's great. Thank you very much. And Angie, are you on the line as well?
Just a reminder, star pound to unmute.
Am I okay?
The there you are. Yep.
Hello, good morning.
Good morning, Angie. So how are things going in Michigan in regards to HCAHPS? What are you seeing?
Well, I think right now we do have 100% participation, and that is due to, with the MB-QIP, everyone signed up to do MB-QIP, and through our quarterly meetings, it was brought up, and and everyone was reminded that they would need to be a part of HCAHPS, and they all have been, but some of them had struggled with the cost of finding a vendor, and so the Center for Rural Health, had looked into vendors, and we're using the Rural Comprehensive Care Network out of Nebraska, and they offer, I don't think they have tons of different types of reporting or benchmarking activity, but they have enough for these hospitals, and I've yet to hear anyone that is not satisfied. They do a mail survey and they report to CMS quarterly. We have, of folks that have been offered this Rural Comprehensive Care Network, there are 8 hospitals that have taken advantage in Michigan, and then the rest have, a lot of them have, the mothership, they have to go with what they're doing. But other than that, that's what we're doing. We've got it covered. As far as I know, everybody is participating. And, of course, our MPRO, our QIO, they have been just phenomenal in helping the hospitals have everything in order to deal with MBQIP. They have made sure that everybody's got everything going to where it's supposed to go, and that was a great relief to me because that wasn't something I was real familiar with. So I think we're doing pretty good.
Yeah, that sounds fantastic. 100% participation is really inspiring. I know that there are some other states that also have 100% participation. I think for Vermont and Massachusetts, maybe Maine as well. Are any of those other folks on the line that could share how they were able to encourage HCAHPS implementation in critical access hospitals?
Hi, this is Angie Charlotte with Illinois. And our board had asked us in our strategic plan a year ago to pursue becoming an HCAHPS vendor for our hospitals, and we are currently conditionally approved and going through targeting our pilot hospital now to become an HCAHPS vendor for our hospitals due to the cost, and they didn't want to participate with some of the larger organizations.
That's great.
Yeah, it's quite the challenge.
Yes, yes. So you have gone through the certification process, or are you still
We're in the middle of it right now.
Okay.
Yes, we'll do our dry run come September, and then hopefully after that get final approval.
Oh, well, that's exciting. Could you keep us posted on your perspective?
I will.
That would be fantastic. Thank you. Are there additional questions or comments folks would like to share regarding HCAHPS?
This is Dave Palm from Nebraska. Can you hear me?
Yes, thank you. Hi, Dave.
Yeah, I just wanted to. We've partnered. I'll make a couple of comments. We partnered with with our hospital association, our QIO, and they had a special hospital association had a special arrangement with the Health Research and Educational Trust, which is an affiliate of AHA, and we've had 2 in-depth webinars and 1 face-to-face meeting just on HCAHPS, where we had about 170 people attend the in-person meeting. So that really has gone very well. We have had, and there's a lot of interest, and we haven't had too much trouble with vendors. Hospitals have selected various vendors, including the Rural Comprehensive Care Network that Angie talked about. But we have had questions. You know, we have some hospitals that have very, very low volume, and thus they don't have very many surveys. And so that question has come up, and it is an issue because, they just don't have very many surveys at all to draw any meaningful conclusions. So that probably will come up if you have some small, very small facilities with very low volumes.
Sure. Yeah, thank you, Dave. And Dave is also the chair of the Quality Improvement Virtual Knowledge, along with Karen Polly from West Virginia. And I know that we've had some conversations within the Virtual Knowledge Group as well as on the Flex Program Forum regarding HCAHPS and some of these issues that Dave has brought up. We encourage continued conversations like that to occur in the Flex Program Forum and also in those virtual knowledge groups. We're going to continue this conversation at the National Flex Program in Bethesda, Maryland, in a couple of weeks here on July 9th and 10th and 11th. We're going to have a special breakout session dedicated to HCAHPS, and it's going to be a panel session and an open, facilitated discussion drilling deeper into HCAHPS issues and looking at some of those tools and resources that are available to assist hospitals in translating the data into actionable process operations. So I look forward to meeting all of you in Washington, D.C. in a couple of weeks. And if there are no further questions, thank you all for your participation.
Thanks.
Thanks.